the Julius Center as an assistant professor of global health, and also with the Noguchi Memorial, with Noguchi, as we all know, University of Ghana, as a postdoctoral fellow on the sports studies. And I will be moderating today's webinar. Before we go on, I would kindly request that we observe a few seconds of silence in respect of the passing away of our former president, that is Jerry John Rawlings. This sad event occurred yesterday, and I would crave your indulgence for some 30 minutes. May we say a prayer for him over the next 30 seconds, sorry. And may his soul rest in perfect peace with his maker. So ladies and gentlemen, welcome once again. And I would like to quickly go on ahead and introduce our guest speaker for today. Her name is Ms. Hedieh Mehrtash, and she has a Bachelor of Science in Human Psychology and a Master of Public Health from Boston University in the USA, with a concentration on global health. She is a postdoctoral degree candidate in the Department of Global Health at the University of Washington School of Public Health in the USA. Her doctoral master is in Global Health Metrics and Implementation Science. Hedieh has training in quantitative research methods, including applied epidemiology, and has research experience in applying these methods to topics in maternal health, safe abortion, and tobacco control. Prior to her appointment at the University of Washington School of Public Health, Hedieh worked as a researcher at the WHO SHR on the portfolio related to quality of care and respectful maternity care, including mistreatment of women during childbirth. Hedieh, I hope I have said all the essential things, and I would now like to give the floor to you so that you go ahead and deliver your message to us. And we really look forward to hearing what you have based on this vast experience you have.
Thank you so much.
I will stop sharing my screen now, and please go on to share yours.
Great. I hope everyone is able to clearly see. Thank you so much, Hannah, for the kind introduction. And thank you for the APECGH team for the invitation. I'm glad to see so many participants today and interested on this topic. So today I'm going to be going over WHO's portfolio on experience of care in maternal health and perinatal health. Particularly, I'll be going over the research, guidelines, and implementation work on this important topic area, especially during the times that we are now in COVID. So just to highlight where we are in terms of quality of care. So as many of you know, in 2018, there were 3 critical reports that came out from the World Bank, from the Commission on Lancet Commission on Quality of Care, and also the National Academy of Medicine in the US, that really focus on the fact that quality of care is now really important and we need to focus more on person-centered care. But what does this mean beyond health systems, and what does this mean for maternal health? So as you may know, WHO has a vision for quality of care, and as you can see here, the experience of care is a huge component of that strategy and that framework. And as such, we've been working on a number of areas to be able to really tease out what experience of care means for women, and what does that mean. So I'm going to go through the research that we've been conducting and leading globally to be able to better understand terminology, but also where we are in different countries, including Ghana as one of our study participants. So briefly, as a background, in 2010, there was a landscape analysis outlining the issue of disrespect and abuse during childbirth that really set the stage for how this issue was viewed globally. Following that, there was the Respectful Maternity Charter in 2011, and then WHO conducted a technical consultation to really understand how we can develop a universal typology of mistreatment of women to be able to measure this and move forward with it. And that was really what preempted our work and our research in this area. Following that, WHO issued a statement, and then the work began. So as many of you know, there's been a very varied use of terminology and framing, with obstetric violence being used in Latin America. And then the issue started with disrespect and abuse earlier on. And then this led to mistreatment of women as another area with a systematic review that I'm going to go over. And then now we are referring to it as respectful care, which encompasses a broader domain, which I'll go into detail. But as you can see, in terms of framing and terminology, there's been really an evolution of how different areas and different people are using and researchers are using this kinds of terminology. So for our purposes, in terms of mistreatment of women, the typology of mistreatment of women was based on a systematic review conducted in 2015. It's based on 65 studies from 34 countries. And the typology is centered around physical abuse, verbal abuse, stigma, discrimination, failure to meet professional standards of care, poor report, health system conditions and constraints. And so WHO has been using the mistreatment of women terminology to really describe this concept and how women should be experiencing care during childbirth. This has now evolved to respectful care, again, another evidence-based systematic review looking at this terminology to encompass a broader conceptualization of what this means to women, including mistreatment of women. But it consists of 12 domains and largely focus on issues that are beyond mistreatment of women, including provision of confidentiality and efficient care and continuity of care. So in terms of how WHO led the research in this area, between 2015 and 2019, we led the study in 2 phases on how women are treated during childbirth. This was a 2-phase study across 4 countries, Nigeria, Ghana, Guinea, Myanmar. Phase 1 that I've referenced some of our work was really qualitative, formative phase, to understand how women are understanding mistreatment, how they're really how each country and each area is exploring what constitutes mistreatment during childbirth in their country. And then phase 2 was a development and validation of the 2 tools to measure quantitatively how mistreatment is during childbirth. And this consisted of 2 tools, the labor observation tool and the community survey tool. And these tools are actually publicly available online and available for everyone's use. And that's the article here on the methodological development. So in terms of what phase 2 consisted of that I just mentioned in terms of measuring mistreatment during childbirth, we prospectively recruited women aged at least 15 years in 12 facilities across the 4 countries. So 3 facilities in each country. Data collection was between September 2016 and 2018. And so the labor observation tool was a continuous observations of labor and childbirth from admission up to 2 hours postpartum. And the community survey tool was administered by interviewers to community up to 8 weeks postpartum. Data were collected on socio-demographic, obstetric history, and the typology of mistreatment that I just went over from the systematic review. The results are published in the Lancet were published in the Lancet in October 2019, and I'm briefly going to go over some of the results with you across the 4 countries. So briefly, before I get into the results, just wanted to give you a sample size of where these different from the different countries and also the 2 tools. So the flow diagram A shows a labor observation tool. We had approximately 2,016 women that were participating. And then we also had 2,672 women across the 4 countries that were participating in the community survey tool. For the purposes of Myanmar, they only participated in the community survey tool. So that's where we have data on women from Myanmar. So as I mentioned, the results that I wanted to go over briefly. So across the 2 tools, you can see the varied results for starting with the physical abuse, verbal abuse, stigma or discrimination domains. And so here, as you can see, it was any physical verbal abuse was highly prevalent across the 4 countries with a range of 40%. And then also, but when you look at stigma and discrimination, there's very few, and that could be due to many reasons of observers not being able to correctly understand what those biases could look like, but also on the side from women to not be able to understand how certain areas and factors could affect how they are being treated. And where does this actually matter for women? When we look at in terms of time, based on what we had from the labor observation tool, we see that women were most affected 15 minutes prior to childbirth, which is a critical time point for physical and verbal abuse based on what we're seeing. They were at an 11 times increased risk of physical abuse compared to 1 hour prior to childbirth, and 6 times at an increased risk of verbal abuse, which highlights the importance of really addressing this issue at this critical time point prior to childbirth. In terms of other areas such as consent and failure to meet professional standards of care, as you can see, for women with episiotomies, there was a really high number of women that were experiencing non-consented care. Approximately 75% of women in the labor observation tool were observed to not have consented care for episiotomies, and women reported 56% of women reported that they also did not experience it, which really highlights that this is a critical issue to also address in terms of meeting professional standards of care and also consent. Even for cesarean sections, we see a small number of women that also reported non-consented care, both observed and self-reported. Moving on to other areas such as vaginal examinations, where there's very limited literature out there, we also examined how women were also consented, but also have their vaginal exams conducted privately. And here we also see high numbers of women being observed to not have consented care, but also reporting that they weren't consented. And simple measures such as privacy, as described here, such as curtains, are things that could be able to help these women experience privacy, but also it shows that really simple measures such as this can help them have better experience of care. And in terms of what constitutes the risk and who is at risk, we saw that adolescent unmarried women between 15 to 19 years were 4 times more likely to have non-consented care. And what does this mean for other areas? This means that vulnerability and inequity is really critical for mistreatment of women during childbirth. As we saw for non-consented care for vaginal examinations, young women were also at an increased risk for physical abuse. They were also at an increased risk for verbal abuse. And for verbal abuse, we see that young women and uneducated women were also more likely to experience this as opposed to others, which shows that we really need to focus on time points of 15 minutes prior to childbirth, but also vulnerable women who might not have a better experience, might not be experiencing care as compared to other women during childbirth. Recently, we also published findings for newborn care practices during the first 2 hours after childbirth. Actually, this is hot off the press. It just came out today. In terms of how newborn are being treated, there's a huge discussion around, okay, so women are being mistreated during childbirth, but what does this mean in terms of newborn? Now, we're not going to be calling it mistreatment per se, as we don't have enough evidence, but in terms of 15 from the data set, we had 15 observed newborn care practices that are listed here that show that not many newborns are receiving equitable care across these different areas. And I encourage you to check out the publication that has just come out. And so the study the secondary analysis really aimed to describe how those practices affect newborn after childbirth, and how can we ensure dignified and high quality of care for both women and their newborn and families after childbirth. And we have a number of forthcoming secondary analyses. We actually have a forthcoming BMJ Global Health Supplement in 2021, which we encourage you to stay tuned on. This is going to look at labor companionship and mistreatment. We're doing also an analysis on adolescents that I had just mentioned. That is a huge vulnerable population, so we're looking into that even more. There's also satisfaction with care, vaginal examinations that we're also looking at. And then we have another number of scale development analyses to be able to refine the two tools and come up with recommendations to shorten the tools. And we also are doing an analysis on linked data. And what does that mean? So we have data for both women that were observed and women that were reporting in the community survey. And we have data for both of these, and we're trying to better understand what areas are lacking in between the two tools. And so we're going to be able to better understand which tools can measure something better than the other. And so stay tuned for this upcoming series. And as the publications are finalized, they'll be published in BMJ Global Health. So in terms of other ongoing work, we're also conducting the same study with the same methodology in the occupied Palestinian territory. This is the first effort in the Middle East EMRO region, and Palestine is leading this effort. We have 3 regions in Gaza, Hebron, and Ramallah, and it's been really interesting to be able to see how the study is being conducted in a conflict setting, but also in the era of COVID, where data collection and methods, we've had to identify methods to be able to adapt the tools for both COVID, for the ongoing COVID pandemic. And so stay tuned for ongoing results and findings from this study as well. So what's next? So we've measured mistreatment. We know that this is an issue across countries. We know we've been talking about the typology. So what's next? We had a working meeting on interventions to reduce mistreatment last year, actually, in person in Geneva with experts in the field. And there's really no magic bullet. There are several drivers to address. There are several drivers that are part of driving this issue, and really a nuanced approach is needed. And so from this meeting, we really wanted to understand how to scope it and whatnot. And currently there's a number of systematic reviews that WHO has commissioned to lead to better understand how we can, through the evidence, understand what kind of interventions can address this phenomenon. So there will be more coming through from this body of work in the next 2 years. In terms of broad areas, so our tools are, one of many. And so there's been a recent systematic review on measuring experience of care, which is embargoed for publication and forthcoming this month, really to better understand, so how do we measure experience? How do we include mistreatment and satisfaction and other tools? So the systematic review will highlight all the tools that are currently available to measure experience of care for women, because there's a ton of literature out there, and I think that this publication will bring it together if folks on this call or others are interested in other tools. So stay tuned for this upcoming publication. So that was my kind of talk and overview of experience of care in terms of research and where WHO is kind of leading the needle and pushing the needle on the knowledge front. I want to go over some of the guidelines and implementation work that we're also leading that are important, because in the end of the day, when having the evidence is one part of the solution, but implementing it and having guidelines to support that is the next phase of pushing that needle, as I mentioned. And so, as you know, WHO has recommendations that are evidence-based, that are available. So I just wanted to highlight 3 key publications, 3 key guidelines that our team leads, which are the antenatal care recommendations, the intrapartum care, and the upcoming postnatal care. And each of these guidelines have recommendations incorporated around respectful care. Particularly the intrapartum care guidelines has 3 recommendations on improving experience of care, which is important to incorporate as countries move forward to person-centered care and more and paying attention more to quality of care for women. And so what does that mean? So as I said, it's really important to translate evidence to national recommendations. And we were lucky that one of our team leads in Guinea was leading this effort nationally. So based on the published literature in October 2019 in Lancet, the Guinea team organized a national stakeholder workshop to be able to develop recommendations to reduce mistreatment of women based on the evidence. And in May 2020, based on the WHO guidelines on intrapartum care and the results from this study, they were able to adopt certain recommendations by the Ministry of Health, and this has now been included in their 2020 to 2024 action plan, which we are thrilled to see the evidence that's being translated. And we also are able to see that stakeholders coming together, multidisciplinary stakeholders coming together to be able to improve this is really important, and thrilled to see the efforts and the work that has come to this stage. In terms of other areas of how the guidelines and the work is being moved forward, so this is a series that was published not long ago in late summer in August 2020 on translating recommendations into clinical practice for intrapartum care. So this is a series really to be able to highlight the optimal intrapartum care in the 21st century, and it includes an aspect on respectful care and how we still need to continue to push for this even in the new era and moving forward in terms of respectful maternity care. We also have a new updated evidence to action brief that was published in September 2020 on labor companion of choice during labor and childbirth. Based on two Cochrane evidence reviews that were published in 2017 and 2019, respectively, we incorporated the new evidence into the evidence action brief to be able to highlight a woman's choice of labor companion and how different recommendations can have uptake for this area as well. So highly encourage folks to check this out as well, including the evidence that is cited. And then moving forward to other areas such as human rights. Last year, there was two bodies of work, two human rights bodies, which was the Council of Europe that actually organized a meeting on obstetric and gynecological violence for Europe. And they published a resolution and report on this, but also the UN. So the UN Special Rapporteur on Violence Against Women prioritized her annual report on this issue. And we had the privilege to organize a meeting between WHO and the Office of the High Commissioner on Human Rights to discuss our evidence and how it can be incorporated using a human rights-based approach. And so we're thrilled also to see the UN Special Rapporteur's both report and presentation to the UN on this topic last year. And most recently, WHO also published a publication on how you operationalize a human rights-based approach to address mistreatment during childbirth. And so we encourage you also to check that publication out that summarizes some of the findings of both reports. In terms of other programmatic areas that WHO works on, there's the Quality of Care Network that Ghana is part of, and other countries, 10 other countries, that really focuses on indicators for improving quality of care for women and newborns nationally. And so this is an interesting effort that's being led by the Maternal, Child Health and Adolescent Department. And then we also have some work on midwives, and there's a report that showed that even midwives are, other than women experiencing mistreatment, midwives are also reporting feeling disrespect and abuse. So it's not just an issue of women who are receiving care, but it's also an issue of professionals reporting that this is an issue. And so the importance of improving those barriers are also critical at this stage. And of course, we cannot forget advocacy and grassroots movements. As many of you know, the Respectful Maternity Care Charter was updated last year. And then there's also the What Women Want ongoing advocacy stream of work, where respectful and dignified care is one of the top 20 demands. And really, I think advocacy and grassroots movements are critical in this time especially in the time of COVID. I think we know that some of the things that we've been doing and we've been advocating for are being disentangled during COVID. Things, there are anecdotal reports of labor companions not being allowed, but it's important during this time to ensure that the evidence still recommends all of these things, and we cannot shy away from paying attention to women and paying attention to their needs, and in making sure that they still experience a positive childbirth even during this time and pandemic. And WHO has guidance on this, and we have 6 recommendations on SRHR and 6 recommendations on maternal health, and also on the clinical management of COVID, we have guidance on a section for caring for women during COVID and pregnancy, which I encourage everyone to look at. So that's all for me, and this is my team. So this is my Supervisor Özge Tunkapu leads the efforts here at WHO, who I work with closely, and happy to take questions.
Thank you very much, Hedieh. This was very, very insightful, and I'm sure we have all learned a lot of things. Thank you so much for this wonderful presentation. I think what we can do is that if you do have a question, you can raise your hand in the chat. You can raise your hand, sorry, in the reaction button. Just use that to raise your hand, and we'll see you and then call you up, unmute you so you can speak. Alternatively, if you want to type in the chat your question, then yeah, we would also be able to read out your question as well. I know some of us require a little bit of time if we need to type it out, so feel free to just take all the time that you need. We still, I think Hedieh has spoken in very good time, and so we can, you know, have enough time for everybody. So I will, yes, I will try and see if I'm seeing some hands up or questions. Perhaps whilst people are waiting to type their questions or trying to figure out how they raise up their hand, I could start with a question that I have, if you don't mind. So I thought it was very interesting, the concept of creating privacy, which we all agree is very essential, and at the same time challenging in low resource settings, because generally we have high fertility rates, the birth rates are much higher, we have less resources in terms of the capacity of our hospitals. So it's good to know that just having a curtain in between created that privacy. However, I also want to, should I say, relate this idea of creating privacy with the concept that you brought up about a labor companion. I'm sure a lot of women would love to have either their mothers or their husband or some family member around. If you look at most of us, our settings, our hospitals are like really big dormitories. You know, the laying wards are like really, really big dormitories. And you realize that as people move around, the curtains are opened and closed sometimes. And so, yeah, we try, but it's technically quite difficult. And I'm just wondering what you found in relation to this labor companion and how it related to creating the privacy in the work that was done.
Sure. That's actually a great question, because one of our secondary analysis is on labor companion and mistreatment. And I would say this analysis was very interesting because it's very context specific. So what happens in Ghana is very different than what happens in Guinea. And I think because of that, because of the enabling environment and because of the things that vary, I think each context in each country and each facility needs to adapt these recommendations to how they best are able to see fit. So if there's a curtain and if there's like a space, if there's a chair for, you know, the sister or the partner or whoever's there for childbirth to be able to be present, that's one area, for example, that can be helpful. But I think it's very context specific, and I think it will depend on leadership at the facilities to be able to make those decisions based on the context.
Thank you very much. Are there any other people with questions? So far, I haven't seen any hand raised.
Yeah, Gifty has a question.
Okay, sure, Gifty. Let me unmute you. Yes, and you can just raise your hand in the screen and I'll try and keep going through the various sections to find the people. Yes.
Hello.
Can you unmute yourself? Yeah, good.
Please, can you hear me?
Yes, Gifty, we can.
Okay, my question is, during childbirth, client refuses to push through on dilated cervix. That is when the cervix is fully dilated. And then there comes in the physical abuse. So what should we do? Should we beat them or should we advise them to push through? Because delayance can cause maternal and fetal death. So what should be the way out then?
Sorry, so if I'm misunderstanding, this is on the provider's physical abuse to women during childbirth. Is that what you're referring to? Sorry, just to clarify the question, if I heard it correctly.
Hello.
Hello.
Yes, my question is, I was asking that during childbirth, clients refuses to push through when the cervix is fully dilated. And then it causes second stage to delay. That will hence result in maternal and fetal death. So if we are not supposed to abuse them physically or verbally, what should be the way out then to help save that?
Thank you for this question. I highly encourage to check out the intrapartum care guidelines. So the intrapartum care guidelines has recommendations on fundal pressure, for example, which was one of the areas that we looked at in terms of physical abuse being one of the parts of physical abuse, and it offers recommendations on how to provide this care. I think in the end of the day, it will encouraging women to feel positive during childbirth will probably allow them to go through labor much easier than the opposite. So I think the respectful care recommendations and the evidence showed this. And so between the intrapartum care guideline recommendations from WHO and the 12 domains that were highlighted, the evidence says positive reinforcement to women will enable them to deliver better and to have a better both experience, but also to deliver better. And I think that it's a change of culture, it's a change of facility culture, it's a change of mindset. And I think that could improve can improve this for everyone involved. I hope that answers your question.
I have a question.
May I add that if you look in the chat, someone put there that regardless of the cause or perceived dangers or consequences, women must not be abused. And I think that is something that we all agree must not happen, because this abuse happens to women across board. You may even be a health worker and you may end up being abused or being disrespected whilst you are in labor in your own health facility. It actually has happened to me. In my own hospital where I was a doctor, on my own ward, I was abused when I was disrespected, let me put it that way. I did not give consent to certain procedures that were done for me during my first childbirth. So this is a subject that I think touches the very core, and no one can be left out of it, whether you're a member of staff, whether it's your very own ward. And I think we need to come out with actionable tools, because again, context is very, very important. We have large dormitories, we want companions, we want privacy. So these are where, these questions must be on our minds. And as we go back to our various facilities, we get the chance to discuss them and see how best to address some of these challenges that may be specific to the settings we are in. I have a couple of people whose hands are up. I see someone called Techno, so I will call Techno first. Cecilia, I have seen your hand up, but Mabel is ahead of you, so I'll come to you, okay? So I will unmute Techno so he can take the floor. Can you unmute now, Techno? Yeah.
Yes. Good evening. This is Peggy. Sorry for not using my name. Please, I wanted to contribute to what the question Sister Vida asked about if we are permitted to abuse, or let me say, beat the women when they refuse to push. I had a client when I was practicing on the ward. She was a primate, 17 years, a teenager. She came to the hospital very composed. And then at the time of assessment, she was 7 cm dilated. I was then a junior colleague, so I informed my senior colleague about her dilatation. And she refused to accept that a primate and a teenager with that dilatation will comport herself clients, and then within a short time she delivered. So I asked the girl what motivated her to comport herself, and she told me that she was psychologically prepared because her mother has really educated her on labor. I didn't even have challenge with her when she was pushing. Her mother has really educated her on labor and what she should expect. And hence she was prepared. So I got to know that if we can really educate our clients even before labor sets in, and then tell them or let them know what we expect them to do at each stage of labor. Thank you.
I think, Peggy, we missed your last few words, but I think you were saying that educating the women as to what to expect during the various stages of labor tends to help. Is that a good summary, Peggy? Okay, I'm not sure Peggy's there. So we'll move on to Mabel. Mabel also has a hand raised, and after that we come to
the network.
And Mabel, you need to unmute yourself. Can you please? Yes.
All right. Hello. Hello. Good evening.
Good evening, Mabel.
Hello. Good evening. Oh, thank you.
Mabel, we can hear you.
I want to contribute. Hello. Please, can you hear me?
Yes.
Hello. All right. Thank you. I want to contribute to this question. Actually, to contribute to what Sister Peggy said, labor and delivery itself is very difficult, and psychologically, even to a second-time mother, it's very serious for them. So all this preparation starts from the antenatal clinic. And so when we psychologically prepare our clients, they know what to expect during labor, the intrapartum period. And then the other thing I also want to encourage with the practicing midwife is that when we take the second stage of labor, we know we have the latent phase and we have the active phase. So most of the time when the client is fully dilated, at least have we access to check if the client is in the active phase. Perhaps the cervix is though fully dilated, but the head has not yet reached the pelvic floor. So we allow the client some time. So within that period, the client is with us during the first stage. That is when we are supposed to also take the client through the things we taught her during the antenatal period and encourage her each and every stage what she's supposed to expect and the consequences behind the person's action. So I think if such a person knows that she's carrying a precious life and how that baby means to we, the healthcare and the entire nation, I think there wouldn't be a need for that client to refuse to bear. I know in exceptional cases, we have very difficult clients who would not like to bear down or push, but then with encouragement, with kind words, with I really don't know if we support them psychologically. They do their best, and I know we have a lot of techniques we can use. It is not actually the best hitting our clients because they go out and
thank you very much, Mabel, for your submission. And I would also like to read something from Isabella. She says every birth is different and women behave differently in labor based on myriad reasons. We need
I think we're having some technical difficulty. Just give us a second.
Hannah, you're muted.
Hi, can you hear me? Sorry, I think something happened with the Wi-Fi. It just went off for a brief second. I'm back now. So I hope you heard what I read about the post someone also said. So I think there's a bit of, should I say, a little bit of divergence of opinions in terms of really, do you really need to be quote unquote abusing, yes or no? And I think it's very interesting, the views and experiences participants are sharing with us. I think this is very, very insightful. Cecilia, are you still on? I'm trying to find Cecilia on my, yes, I found you. Yes, I've asked for you to unmute, so please unmute yourself.
Okay.
Yes, great.
Yeah, please, I just want to add to what they've said. In managing a labor case, it all deals with the education and the zeal of the midwife to actually help the labor woman. Because I have practiced for very long, and then in any case, when they come in the first stage, your approach to them will really let them know whether they will go through this successful or not. Sometimes you already put fear in them from the onset. So when they come in and you take them through the real processes, at this stage, this is what you'll be experiencing. And when you get here, these are what you are supposed to do so that you cooperate well and help you. I think the clients, though there might be few odd ones, but majority of them will cooperate. So when you get to the third stage where, the second stage where client had to bear down and then maybe there's exhaustion or client is not cooperating, you try to find out the cause first. It could be that the woman is exhausted. She's not having any little strength left. So if you kept beating or you try to abuse her because you want to save the life of the baby, don't forget that we are handling 2 lives. So in my practice, I always start from the onset. When the woman comes, I'll take your card through the history. I'll get to know the stage of labor you are in. Then I will continue from there what you are to expect and what you should be doing for me to help you, and both of us will end successfully. And you, your family, and I handling you will also be happy and they get the outcome very lovely. So in abuse, actually, I don't see the effort of midwives trying to abuse women because we want to save lives. So if we put the right education from the onset and then you guide them, sometimes we neglect them until they get to the serious stage, then we will now be rushing and be using all sort of abusive words and things to hasten up what we were supposed to manage. But if you do proper managing from onset to the end with the client, I think that this abuse thing will end. That is just my little contribution.
Thank you very much, Cecilia. So I will go to Angela. Angela, could you please unmute yourself? Angela? Do we have Angela? Angela, you're unmuted, so you can make your submission, please.
Good evening. Yes.
Good evening,
Yes.
Angela.
Good evening. Good evening.
Good evening.
Okay, good evening. And just to add a little to it, I think
Angela, I can't hear you. Angela, unfortunately, we cannot hear you at all. I think that's a problem with the internet. So maybe what you could do for us, Angela, if you could take a little bit of time to type in your comments and contribution. Please try and type in the chats your comments and contribution, Angela. Sorry, but it looks like the internet is not helping.
Good evening. To add a little.
Okay, so Angela, please type in the chat and we will move on to, we had Augustina. Augustina, can you unmute yourself, please? Augustina? Augustina, can you please unmute?
Good evening.
Yes.
There's this thing that I want to. Hello? Hello?
We can hear you now.
Hello? Yeah, good evening.
Good evening.
There's this one that I want to find out about the consent of a woman during episiotomy and VE. Should it be verbally or should it be something that they should sign?
It's verbal.
I didn't get it well from that side.
Sure.
It should be verbally.
Can be done verbally as long as the woman is informed about what procedure is occurring to her. So it's as long as the woman is informed and doesn't wake up with an episiotomy or doesn't realize that she's an episiotomy after. It's as long as the woman is informed about her choices and to make those choices for herself. And so I think it doesn't matter how it is as long as it's done.
Okay, great.
Thank you.
I think we have Kuma. Kuma, can you please? Hello, can Kuma please unmute and make her submission? Kuma, are you there? Okay, so we will then move on to Gifty and then Kuma, I'll get back to you when you are able to unmute. Gifty, can you please unmute now and make your submission?
Hello?
Yes. Sorry, it looks like
please.
I'm getting some glitches with my internet, so it keeps going off sometimes for just a few seconds. My apologies for that, but Gifty, please go ahead with your submission. And after Gifty,
Please, I wanted to find out about the episiotomy. Hello?
Yes, go ahead.
Yes, about the episiotomy consent. If client denies she doesn't want the episiotomy to be done for safe delivery, what should you do? Because in a situation during assessment, you find out that the vagina is not roomy for delivery, and so you have to do the episiotomy. And then you tell the client that you explain to the client that this and that you want to do, and then she will tell you no, because people once told that when they do episiotomy on them, the wound doesn't heal, and then the place is left vacant, and then it gives, and then hence and so I wanted to find out if the client denies episiotomy to be done, what should be the way forward then? Hello.
So yeah, so I can briefly answer. I mean, as long as you, in the end of the day, the woman has to be informed why the procedure is happening, for what reason. And I think going ahead of doing this episiotomy without informing her won't necessarily be helpful. But if you are explaining and again, explaining, so the consent actually that we have, the variable that we created, it was actually based on 2 questions that where we used consented care. One was explained. So was the procedure explained to women? Part 2 of that question that became non-consented care is then, did she permit you to then conduct that procedure? So it's really about, consent is 2 parts. It's about explaining and also and then also the aspect of permitting. And so I think, you know, here in this instance and in these cases, you are explaining, and then, you know, the permission will have to come because, as you said, you're trying to save her life, etc. But as long as that's done in a communicative fashion, that you have a rapport with women, that you are, you know, informing her about her choices, you know, then that's where respectful maternity care sits, is as a provider, to pay attention to women's choices and make decisions and make informed choices based on her decisions and her choices. And so I think in that sense, communicating that is the most critical and most and key in this instance. I hope that helps answer the questions. And I would encourage you to look at some of the domains and some of these areas to be able to see, because consent sounds like you know, a big task, but really explaining it is step 1 of the way.
Thank you very much for that explanation. So perhaps what I would say or contribute to this conversation is whether or not we, you know, having the education done prior to labor, whether during the ANC it becomes useful to have conversations as to what to expect in labor, because personally, I don't recollect being educated, for instance, about episiotomy when you are in labor. People just, I don't know if we do that kind of education. I'm just asking myself, if we were to tell women that, well, it is possible that we may have to cut you just a little bit down there to make more room for the baby, will it make a difference? And I think it'll be interesting to hear your thoughts about doing something like this. But I don't think this is one of the key messages or education messages we deliver to our clients when they come to us during the antenatal period. And like someone said, during labor, your mind is really sometimes on the pain more than anything else. But
I think that's a great point, Hannah, because so the systematic review that's coming out in November 2020 will highlight all the tools that we can measure experience of care of women, even during antenatal care. I think I think it's critical at any point during the continuum of care. And I think the new review that will come out will also have tools that we can systematically measure that and use certain indicators to be able to measure, and as you said, to be able to understand that better, and starting even from antenatal care. So at all time points, even postnatal care, it's critical.
Thanks. I would like to read something from Angela in the post. It says, I think it's about time we intensify our antenatal school, where we introduce the pregnant women to the stages of labor for what exactly goes on during labor, so that at the time of labor, they know what to do, so they would not incur any form of abuse. Thank you very much for that submission. Isabella also put here, episiotomy. We don't, this is not mandatory for every woman, according to the evidence. It's not a routine procedure, and says, I agree with Sasha. So I'm sure Sasha wrote something else about cutting or having
from Isabella and Sasha. I'm looking through the chat. Thank you.
Yeah, okay, thanks. Do we have any other hands raised? I'm going through again the participants to see if there is anyone. Okay, so I think there's
some time ago.
Susan.
I wanted to say something, but I'm not sure whether Koiba still wants to say something.
Huh?
Rekia, I think Kowa, you can make your submission.
Nah.
Koiwa, are you there? Other than that, I think you can go ahead and make your submission and Koiwa comes in a bit later. And then after that, we shall have Stephanie, because I see her hand.
So, sorry, Hannah, did you say I should speak or?
Yes, please go ahead.
I
can't seem to get Koiwa.
Okay, yeah, but that was the only thing I wanted to say actually. But now I'm speaking anyway. I do actually have a question for Hedieh. You know, given the questions about how to exactly do this informed consent, you know, which I can well imagine that it sounds much more simple than it is in practice, especially when there's pressure, you're tired, there are risks at stake. Does the WHO also, do you have any guidance documents on how to actually do this? How to do the informed consent procedure in practice?
I believe it's in the intrapartum care guidelines. It has 56 recommendations. So I encourage you to look through that in terms of the process as part of intrapartum care.
From the top of my head, I don't think there's much detail there about it.
Okay,
but
on the informed consent, yeah. But it's a good point. It's a good point for us to raise, and I know that we also have the labor care guide that's coming up, and I believe stay tuned for that. It's a labor care guide for the intrapartum care that might have some of those details. If not offline, I can share more resources on this aspect. Mm-hmm.
Okay, are there any pressing questions? I saw Stephanie. Stephanie, you wanted to ask or make a submission? Stephanie, you can unmute yourself, please. Do we have Stephanie there? Okay, then we'll move on to Gifty because I see Gifty is also asking to be unmuted. Okay, I think that we would like to move on then to back to the slides I was sharing previously to also throw some questions back to you, our audience and our participants as we deliberate on this subject matter. Please, if you do have any further questions, do well to put them in the chats and then we will try to address them before the end of this session. So I will share my screen. And this. Can you all see my screen? Okay, great. So I actually mixed a few questions that traditionally would have asked you at the beginning and tried to put them in the chats. So perhaps we'll start off with this. We've had a lot of talk about, respectful maternal care already. So if you could just indicate in the chats, what does respectful maternal care mean to you? That will be great. And then I will give you a few minutes to do that. And then I'll move on to the next slide for us to continue with our deliberation. So perhaps a minute or two for us to write in the chats what respectful maternal care means to us. And I will try and read what pops up, some of what pops up. Okay, are there any, please feel free to type in I'm not seeing any responses so far as to what respectful maternal care means. Okay, so I have Isabella there already. As a midwife, respectful maternal care means culturally sensitive care, basing actions on evidence and involving the woman and significant other every step of the way. It means I will listen to the woman when she says no and when she says yes. Do we have a few more people contributing to this? So Gina says, providing care that focuses on prioritizing the health of the patient and aligns with the wishes of the patient. Susan says, respectful care means showing and being compassionate to the woman in labor, helping relieve pain and providing encouragement in a positive way. Oh, in a positive and non-abusive way. Thank you. Okay, great. So we have a couple of answers there. Please do keep your answers coming in. I would like to move on to the next slide. Do you see my screen? Has it moved on to the next slide? Please give me a thumbs up if you can see the next slide. Gina says she cannot still see the next slide. Let me try and figure out what is happening here with Zoom. I will please stop sharing and reshare and see if that works. Let's see what is going on. Yes. Can you see the next slide now? Okay, great. So we have some questions that we wanted to throw back to you, our audience. So there's this question we have here. Do you think some respectful maternal care domains are challenging to achieve or unsuitable for the Ghanaian context where you live or work? Which ones and why? So if you do not live or work in Ghana, please just do well to indicate which country you are from and indicate which one of these domains that you think is just difficult to achieve in your setting. I think for those of us who may be a little bit slow with typing, what we could do is that just carefully count, because there are 12 domains, and you can just put in the chats that for me, I think that number 2 is a challenge in my country, Mali, Ghana, something like that. It's also just fine, but you need to carefully count so that you can be sure that what you're asking for is what it is. Okay, so someone says number 10. Someone says caregiving to women during pregnancy, intra and postnatal involving the woman and relatives.
And the slide shifted. Can you put it back?
Oh, sorry. Is it back? Back here, is it back?
No, not yes, now it is. Yeah, yeah. But if you,
okay, great.
You put it on full full view.
It's still not full. Oh, yeah. Okay, great. Rakia, I may like to ask for your help here if you can help with reading the chats, because it looks like when I try to move to reading the chats, then some of the things start moving. So if there are any responses,
okay,
the colleagues, please let them read it out for us.
Okay, so Isabella is saying number 10, availability of competent and motivated human resources might be particularly challenging in the Ghanaian setting, I think. Stephanie is saying rendering service to women during pregnancy, labor, etc., whilst maintaining her dignity and also ensuring privacy. Susan is saying, I'm from the US and recently started working in Lagos, Nigeria. All this is new information, as I never realized women were treated badly during labor and delivery, which is very interesting. Anita is saying maintaining privacy may be difficult due to the poor infrastructure, like you were saying as well, Hannah. I think I missed a point perhaps by Abigail. Let me just see. Sasha, maybe you can also say what you're responding to there.
Yeah, Abigail was talking about, so she said, looking at the number of participants, I think in this presentation, we have a long way to go. We need to maximize publicity on the subject because a lot of women are suffering under our hands. And I thought that was a really important point, that if we want to shift disrespectful maternity care practice to respectful ones, we also have to take accountability and acknowledge that we're learning. So I thought that was a really important point from Abigail. That includes that we can change, and that change is a continuous process too. And yeah, so I thought that was a great point.
Okay. Thanks a lot, Sasha. So please keep your questions coming in, and we'll share all this with you as well, so you know who said what, and you can deliberate on this as you go back to your various workplaces. I'd like to move on to the next question, which are the respectful maternal care principles especially relevant? Providers care for women with in circumstances of, for instance, preeclampsia. And we asked specifically about preeclampsia because I think you know the uniqueness of the SPOT study and of APECGH, because we are working specifically in this area. So we are also interested in knowing your thoughts on this. So please keep those coming in the chats. And again, I would like to please ask Brekia and Sasha to help to read up the chats as they show up. Please do not forget to indicate your country, especially if you are not from Ghana as well, as you respond to question number 2.
So we have a chat from Linda, which may still be about the previous question, but she's saying, because from my facility, education of the mother starts the moment she enters the facility, and that goes a long way to help save delivery.
That's an interesting point.
Hannah, maybe it might help if you go back to the previous slide which lists the 12 principles or domains.
Okay, sure.
Then people can see that again. So the question is really like, okay, if you think about specifically patients with eclampsia or preeclampsia who are very ill, what is maybe particularly important then? So Anita is saying, I believe giving the client an informed consent is then very salient. Interesting. Cecilia is saying, what can the young midwives who have been updated in care to mothers but are still working with our old midwives who seem to know it all, in the words, with the outmoded practices? Interesting. Can we ask people maybe also to elaborate a little bit? Because I find both these points actually from Anita and Cecilia very interesting. So maybe Cecilia or Anita, would you be willing to unmute yourself?
Maybe we can start with Anita, because it's an A in alphabetical order. Anita, kindly unmute yourself if it is possible for you to elaborate a little bit more on this. Okay, we're not hearing from Anita yet. Are there any other, it was Anita and who, sorry, Brekia, I can't see the chats.
Cecilia.
Cecilia, yes, Cecilia, so please.
About the generational difference between midwives.
Cecilia, if you feel like you'd like to talk about this a bit more, like we're asking, go ahead and unmute yourself.
And I read that Anita is not able to unmute herself at the moment. It's not working, sadly. You can also type more in the chat if you'd like, Anita, to explain a bit more why you found that especially important.
Okay, so whilst they are perhaps typing in the chat, we can look at question 3, which is, in your view, how could the WHO best promote and facilitate the provision of respectful maternal care in Ghana? And again, if you are not working or living in Ghana, just indicate your country and what you think WHO can do to promote respectful maternal care as well.
And in the meantime, I think it's worth sharing some more thoughts here. So Isabella is saying respectful maternity care is very important in preeclampsia management. Many women report late for several reasons, and one of them is the attitude of the health provider. And Mary is saying listening to the client is a challenge and rendering passionate services to especially the pregnant woman. Abigail saying, I'm working in a village in Ghana, but we're trying our best so our clients have minimized patronage of TBAs and our attendance has increased. And Linda thinks that a policy and protocol should be put in place to ensure adherence from both mothers and staff. And Gina from the Netherlands suggests that communication is especially important, thinking back to the previous webinar where we heard some of previous patient stories who went through preeclampsia or eclampsia and had heartbreaking stories to tell about their births and the loss of baby. And she thinks it's imperative to have effective communication, which was also confirmed by another participant.
I think these are very interesting thoughts and comments, and the conversation overall is a very, very interesting one. However, I'm also mindful of our time because we have just, I think, another 6 minutes to round up this webinar. Please do well to keep putting your chats in there, and we will definitely use the information that you give to us in our all the conversations we have. I'm sure we will be deliberating on these issues to go back to our respective workplaces. So I would like to move on to wrap up this meeting that we have had today. I think that in summary, we have talked a lot about respectful maternal care. And I think for me, one of the key issues that I think we need to deliberate on is the ideology that our midwives have in relation to how to manage pregnant women, particularly in labor, which is where we talk of a lot of, mistreatment or disrespectful care occurring in this particular conversation. And I think this links up very well to, I think, the points made by Anita, for instance, concerning, well, perhaps the generational gap can influence how practice of midwifery or what is done during labor occurs. So I think it's food for thought for all of us. How do we kind of bridge this generational gap? How do we tackle the issue of midwife ideology perceptions towards how women should be managed when they are? It's a point I put there, and I think I would like us to leave having this at the back of our mind. So to wrap up, I would say thank you very much for being part of this webinar. We do have certificates available, and it comes at a cost because we have to do some printing and all, if you want the hard copies as well. And please indicate if you want this certificate of participation, because this program is accredited by the Midwifery Council and it goes at a cost of 55 cedis. And do send in your requests and your funds by the 21st of November 2020. If you do want to get this certificate, there's a link that I have projected up here, and I'll please ask for Sasha or Brekia to also put in the chat so that people can copy paste as well, so that if you fill that form, we can get back to you on that. We'd also like to have a lot of feedback from everyone who participated in this webinar. And for that as well, I would also ask that my colleagues put up the link to the feedback form. Please do fill it so that we receive some feedback in order for us to be able to improve subsequent webinars. This is not the end of respectful maternity care. It is a big issue, and there will be a part 3 of this series, and it will be on Tuesday, not a Friday. Most of our webinars have been on Friday. This time it's on Tuesday, November 24th, 2020. So please note that and put it in your calendar so that you do not miss this session. For APECGH Ghana, I think that it's, as usual, we also like to engage our participants and ask, how can you support us? You can volunteer your time, your expertise. You can also follow APECGH on social media through Facebook, Twitter, Instagram, and you can also be a sponsor, a partner, a collaborator with APECGH Ghana. So please do well to get in touch with APECGH Ghana through these channels, if you're able to. If you also do want to donate the course of APECGH Ghana, which is focused so much on getting the communities and women sensitized about preeclampsia and how it affects pregnancy, it affects outcomes of pregnancy, please feel free to also donate to them, and the bank account details has also been provided on your screen. If you want to do e-payment via Momo, which is also very popular, we have provided the mobile number as well. So I think this is about my final slide. We wanted to acknowledge all the colleagues, both present and not present, who have also facilitated in putting this webinar together. I don't think I can mention everybody's name, but this is to acknowledge everybody who is part of sport, part of APECGH, all collaborators who have engaged with us and helped us to organize this. For you to be able to get to the sport website, we have also provided some details, sportsteadyghana.com. You can look it up, and partners are the Greater Accra Regional Hospital, mDoc, Quick Medical Consult as well. So I think that was my last slide. And I would like to say a very big thank you to Hedieh, because I know that we've taken up a bit of your time, even as you're also preparing to move on with your PhD work. We really appreciate you making time for us. We hope that during the next session, you would also be able to learn, join us to also, learn and have a conversation with all of us. So thank you all very much for the webinar. Okay. Thank you all, and do have an enjoyable weekend.
Yes. Bye-bye.
Bye.
Thank you, everyone.
So let's just wait for participants to leave, and then we can just have a brief discussion. Yes.
Yes, sure.
Are you?